friends, this is Nishant Gautam, Associate Professor from the Department of Pharmacology. Today we will study about the pharmacology of coagulants and anticoagulants. According to your syllabus, this is the third chapter of your second unit, that is the pharmacology of drugs acting on cardiovascular system. So, in continuation to part 3 of the chapter coagulant and anticoagulant, now we will continue the topic direct factor 10 inhibitors. So, already we studied in the classification the inhibition of the activated 10th factor and how it is responsible for the coagulation cascade, and its inhibition shows the anticoagulant effect. So the drug Rivaroxaban and Apixaban is an orally active direct inhibitor of activated factor 10, which has become available for prophylaxis and treatment of deep vein thrombosis, denoted as DVT in medical terminology. Its anticoagulant action develops rapidly within 3 to 4 hours of ingestion and lasts for up to the 24 hours. Further, it requires no laboratory monitoring of PT or APTT and is recommended in a fixed dose of 10 mg once daily, starting 6 to 10 hours after surgery for prophylaxis of vein thromboembolism, following total knee hip replacement. Then, in comparative trials, its efficacy has been found similar to a regimen of low molecular weight heparin followed by warfarin. Further, rivaroxaban has also been found equally effective as warfarin for preventing stroke in patients with atrial fibrillation. And at last, the side effects reported are the bleeding, nausea, hypotension, tachycardia, and edema. With this, another class of the drug, oral direct thrombin inhibitor, is Dabigatran, etexilate. This drug, having a prodrug effect, so it's a prodrug which after oral administration is rapidly hydrolyzed to dabigatran, a direct thrombin inhibitor, which reversibly block the catalytic side of thrombin and produces a rapid, that is within 2 hours, the anticoagulant action. In the UK, Canada, and Europe, it is approved for prevention of venous thromboembolism following a hip knee joint replacement surgery, and the administered in a dose of 110 mg, that is 75 mg per elder greater than the 75 years. Once daily, it has been found comparable to warfarin. In another large trial, dabigatran, etexilate 150 mg twice daily has yielded superior result to warfarin for prevention of embolism and stroke in patients with atrial fibrillation. Then, in US, it is approved for this indication. Adverse effects are bleeding and less commonly hepatobiliary disorders. Then the another class of anticoagulants are the oral anticoagulants, that is the warfarin sodium. So warfarin sodium and the related compounds are chemically various derivatives of 4-hydroxycoumarin are available and have the activity as vitamin K antagonist. They inhibits the activity of K as a coagulant. Then here discuss the mechanism of the action of the warfarin, how it is showing its anticoagulant effect. So see this flow chart, here it is clearly given that how the warfarin showing its anticoagulant action. In this chart, see the green color, here they wrote blocked by the oral anticoagulants. This blocked by oral anticoagulants, that means the warfarin. This is the action site of the warfarin. So warfarin and its cogeners act as anticoagulants only in vivo, not in vitro. This is so because they act indirectly by interfering with the synthesis of vitamin K dependent clotting factors in liver. They apparently behave as a competitive antagonist of vitamin K and lower the plasma level of functional clotting factors in a dose dependent manner. In fact, they inhibit the enzyme vitamin K epoxide reductase. See in this diagram how it is inhibiting and interfere with the regeneration of the active hydroquinone form of the vitamin K. This hydroquinone form of vitamin K acts as a cofactor for the enzyme gamma glutamyl carboxylase that carries out the final step for the gamma carboxylating glutamate residue of prothrombin, and for the factors 7, 9, 10. This carboxylation is essential for the availability of the clotting factor to bind with that of the calcium and to get bound to phospholipid surface, which is necessary for the coagulation sequence to proceed. Now come to its pharmacological properties. The usual adult dose of warfarin is 2 to 5 mg per day for 2 to 4 days, followed by 1 to 10 mg per day as indicated by measurements of the international normalized ratio. Because of the long T half of some of the coagulation factors, in particular factor 2, the full antithrombotic effect of warfarin is not achieved for several days. Then also warfarin given intravenously without modification of the dose, intramuscular injection is not recommended because of the risk of hematoma formation. With this, the polymorphism of warfarin is also there. It is due to the fact that there are the two genes cytochrome Y P2C9 and vitamin K epoxide reductase complex subunit 1, both accounts for most of the genetic contribution to the variability in the warfarin response in the different patient depending on the gene or races. So here I summarize in this table cytochrome Y P2C9 and the vitamin K epoxide reductase complex showing the pharmacokinetics and pharmacodynamics respectively. In case of cytochrome P2C9, the pharmacokinetic, if you will see, there is a common variation in the gene are associated with higher drug concentration and reduce the warfarin dose requirements. On another hand, the vitamin K epoxide reductase complex subunit 1, if you will see the pharmacodynamics, the polymorphism in this explains the 30% of the variability in warfarin dose requirements. Then the therapeutic uses of the warfarin. It is used in the treatment and prevention of deep vein thrombosis in bedridden, immobilized patients, old people, post-operative conditions, post-stroke patients, leg fractures, elective surgeries, and also it is used in ischemic heart disease, unstable angina, and in after myocardial infarction, after angioplasty, and after the coronary artery bypass, grafting, stent replacement, prevent recurrence, and also used in rheumatic heart disease, atrial fibrillation. The warfarin heparin dose is used. The low dose aspirin decreases the stroke due to emboli. In addition to this, some more therapeutic uses of warfarin is in the cerebrovascular diseases. That is in the cerebral emboli. It is the drug which is used in the recurrence or the prevention of the recurrence of same. In vascular surgery, prosthetic heart valves, retinal vessel thrombosis, extracorporeal circulation, hemodialysis, this drug is used to prevent thromboembolism. In addition to this, defibrillation syndrome or DIC. Here, the abruptio placenta, malignancy, infections, or increased consumption of clotting factors. For this, also we are using the drug warfarin. Then, let us study about the adverse effect and the toxicities of this drug. The first one is hemorrhage. International normalized ratio should be maintained between 2 to 3 and the risk of bleeding is potentiated beyond the international normalized ratio up to the 3, and the risk of intracranial hemorrhage, gastrointestinal bleeding, intraperitoneal, retroperitoneal bleeding increases, and the vitamin K supplementation IV or oral is required when the international normalized ratio is more than 5 with the temporary discontinuation of the drug. Then the birth defect is also a important thing. Here the administration of warfarin during pregnancy may cause the birth defect and the abortion. A syndrome characterized by nasal hypoplasia and stippled epiphyseal calcifications and resemble chondrodysplasia punctata may result from maternal ingestion of warfarin during the first trimester. And the third one is the skin necrosis, but it is very rare. Then the purple toe syndrome is also another adverse and the toxic effect of warfarin. It is painful blue tighten discoloration of the plantular surface and side of the toes that balances with pressure and fades with elevation of the leg. Then come to the next point, contraindications. The contraindications are hypersensitivity, bleeding disorder like hemophilia, thrombocytopenia, intracranial hemorrhage, GIT ulcerations, threatened abortion, and the advanced renal or hepatic diseases. Some other vitamin K antagonists are summarized here in this table. First one is pharmacology. It has a longer plasma half-life, that is up to 5 days, than that of the warfarin, as well as a somewhat slower onset of action and a longer duration of action, that is 7 to 14 days. Whereas the another vitamin K antagonist is acinocomerol, which has the shorter half-life, 10 to 24 hours, a more rapid effect on the PT, and a shorter duration of action, that is of the 2 days. The maintenance dose is 1 to 8 mg daily. Whereas the third vitamin K antagonist, Indandione, it's similar to warfarin in its kinetics of action and has higher chance of the hypersensitivity. Then, Indandione derivatives. There are the two Indandione derivatives. The first one is Anticoagulants. The name of the marketed preparation is Indandione. Is available for clinical use in some of the countries. It is similar to warfarin in its kinetics of action, but offers no longer advantages and may have a higher frequency of untoward effects. The second one is the Phanedione. The name of the marketed preparation is Indavan. It is still available in some of the countries and it is having the problem that it shows the serious hypersensitivity reactions, occasionally fatal, can occur within a few weeks of starting therapy with this drug, and its use can no longer be recommended. So, as a summary of this chapter, coagulant and anticoagulant, we can summarize the drug interactions with the help of this chart. Here, three categories are there. The drugs that increases the warfarin activity. It is with the help of the three mechanisms, and these three mechanisms is due to the use of three different kinds of the drug. Like that, the aspirin and sulfonamide decreases the warfarin binding to the albumin, whereas the cimetidine inhibits the degradation of the warfarin, so that the there is a increase in the warfarin activity, whereas the oral antibiotics decreases the synthesis of the clotting factors, so also there is the increase in the warfarin activity. The another category is the drug that promoting the bleeding. The use of aspirin shows the inhibition of the platelets are responsible for the inhibition of the platelet aggregation, so that these drugs promoting the bleeding. Then the heparin and antimetabolites in showing the inhibition of clotting factors, So there is a increase in the bleeding. And the third category is the drugs decreasing the warfarin activity. The first one is the drug barbiturate. Through the induction of metabolizing enzyme, it decreases the warfarin activity. And the another is the use of vitamin K that increases the synthesis of clotting factor, so that there is a decrease in the warfarin activity. It is likewise, and it is how the drug interaction takes place into the three categories. So that's all for the day, and so we finished the chapter coagulants and anticoagulant, and we will study the next chapter of the second unit. Till that, have a nice day and thank you.